Lana?
Yeah, I think, obviously people will be coming in and joining us. We'll go ahead and get started.
So that's the housekeeping. Just welcome to everyone. Really glad to have you all here and joining us for the webinar. We just welcomed our new cohort of 2021 Champion Provider Fellows, and some of them may be on as well. So a few of the housekeeping things are posted, but just note that you'll be muted throughout the presentation. You can use the chat to enter any question and answers or anything for our Q&A, and we'll address those as we go, and also have some time at the end of the presentation to get to that too. And there will be a recording of this that will be available for everyone to listen to later. Any other, so we have some programming updates. I won't go through everything, but just want to remind you guys that we have the Persuasive Narrative series, and that first session is coming up on February 23rd. And we have a few other webinars as well, are engaging with community-based organizations on the 16th, and our onboarding training are also coming up in March. So please keep an eye out for that, and you can go to the website to see a list of all of our upcoming events. So Alicia, so it's my great pleasure to introduce Dr. Alicia Fernández, who is familiar to many of you. She's been with Champion since it started, and has been a wonderful, wonderful resource to our fellows in advancing their work. She's a professor of medicine at UCSF and an internist at our hospital, San Francisco General, where she practices primary care. And her work, research has been focused around healthcare disparities with a focus on diabetes, Latino health, immigrant health, and language barriers. She has a number of accomplishments. So she's a member of the UCSF Academy of, I know, Lucy's gonna make me blow by all of this stuff, but
yeah, let's go. That way we have more time for dialogue.
Yes. Well, I will at least say that she's a director of the UCSF Latinx Center of Excellence, which has been extremely active and important in COVID-19 specifically, and really addressing the disparities that we're seeing in this pandemic. And so we're really happy to have Alicia joining us today to talk about the work that she's been involved in, and local and regional response efforts related to the COVID-19 pandemic, especially for the Latinx community, and how she's thought about her work in terms of framing PSE interventions within a health equity mindset, which is something that's really at the root of what we think about with Champions. So,
thank you very much. Thank you very much. That was a lovely introduction. Hi, everyone. I'm really glad to have an opportunity to talk with you. I don't think I know you quite as well as I know other groups, and it'll be a pleasure to get to dialogue with you. I am going to, let's see, I'm going to share my screen. This is always the hardest part of giving a talk. Sharing my screen, here I go. And, nope, sorry. Here we go. And how do I get it on here?
Alicia, yeah, right there, perfect.
There, can you guys see that? Perfectly. Okay, so what I want to do today is I want to blow through some of the data, because I actually think it's pretty well known to you guys, to try to get to some of the policy issues and how we can address those. And I'm particularly interested in keeping this part short and engaging in dialogue, because I think that that'll be interesting to all of us. And also that's where we can try to see if we can extract generalizable lessons for some of the great work that you're doing in combating obesity. So obviously, I think everyone knows that COVID-19 has hit different communities very hard. Because a lot of my talk as a Californian and as someone in the Latinx Center of Excellence is focused on Latinos, I really want to acknowledge that if you look at overall mortality in the United States, and here's COVID mortality, and you look at how much the county is percent African-American, you will see that as the county becomes more African-American, as we go out this way, mortality tends to go up. And here, these orange dots are Georgia, and the gray dots are non-Georgia counties. But you can see, you can get this relationship. African Americans and Latinos both have around between 3 and 4 times the mortality of white Americans in COVID. Some of this data became very quickly visible when from New York City, when the epidemic first struck. And here are New York City death rates, examining them by race and ethnicity. And you can see the large overrepresentation here. Or when you look at it by poverty, low poverty areas to high poverty areas, you can see again the number of cases going up. And then here, something that's always super important to acknowledge is that if a Martian were to come down to Earth and look at death rates on COVID-19, what would strike the Martian most would be obviously that this is how mortal this disease has been among older people, and that it's really older people who have carried the brunt of mortality. But not only older people. And so I want to just give you California data. I pulled this data this morning. So this is hot off the press. We're looking at ethnicity here. And what we're seeing here is that wherever the line is, this is the number of cases that would be expected proportional to the population. So we can see that proportional to the California population, we have a low percentage among whites, much less than the California population because it doesn't reach this bar. And then you can you see my cursor? No, not really. Now can you see my cursor? Okay, proportional to the California population, it's really below, whereas you can see that for Latinos, it exceeds the proportionality it exceeds the proportion in the population. So that is cases. And with mortality, it follows. And you can see here that the Latino mortality, again, of most of the groups is the one that is in excess in California, disproportionate to the number of people in the population. The California website on COVID also has the data on household income, and we can see here that the cases are more common among poorer people, particularly in this group of 0 to 40,000. In other words, among the most extremely poor people is where we see the most cases per 100,000. And among the most well-to-do is where we see 12 cases per 100,000 as opposed to 36 cases per 100,000. This lets you compare the magnitude of that difference. So we're seeing 3 times as many cases among the poorest group than we are among the wealthiest group. And similarly here, case rate per 100,000 statewide, it says 32, but among people living in crowded houses, it's 43%. And among people who have the least amount of crowding, the percentage of the community that lives in uncrowded housing, it is much less. And you can see how sort of linear these relationships are. And finally, here we have, here we have healthcare access among people where many people in the community do not have health insurance. The case rate is 43 per 100,000, whereas in communities where most people, or fewer than 5%, don't have health insurance, the case rate is 1/3 of that in the state at 11 per 100,000. I hope this is not overwhelming you with data, but I want people to know, and I think everyone does know, but first, A, you can look at these yourself in the COVID website, but B, the data are pretty overwhelming in the story that they tell. So today I pulled the numbers. New York City is about 10 times the population of San Francisco, but New York City has had 554 cases and San Francisco only 32,000 cases. So way more than 10 times. And then for deaths, way more than 10 times as many deaths. And I put this here because I think it's very important to show that to remind us of what happens when a healthcare system becomes overwhelmed, as happened in New York City with the first wave of the pandemic. And it's because of that, New York City has many, I think it's 7 medical schools. It's an outstanding, obviously outstanding healthcare system. But it's just a reminder where flattening the curve comes from. We wanted to flatten the curve partly so that people would not get sick and die, but partly to protect the healthcare systems, because what happens when the healthcare system gets overwhelmed is that we have many more deaths. Many of you may have seen the article, I believe it was in yesterday's New York Times, about, or a day before, about 2 families with COVID-19 who were taken to who went to hospitals in LA, and how unfortunately going to a hospital with a lot of high poverty rates meant that they did not have access to the type of care that is keeping the death rate down in San Francisco. I also wanted to share some local data. This is data that I was not involved with. This is data that came out of a coalition from my colleagues in the Department of HIV and AIDS, Diane Havler and other colleagues, and a community-based organization called the Latino Task Force in the Mission. And what they did was as you may know, San Francisco sort of looks like this. The Mission neighborhood is here. And within the Mission neighborhood, they chose just one census tract, which is the second most dense in San Francisco. It had almost 5,000 persons, and 60% of those people are self-identified Latinos on the US Census data, and about 34% had a household income of under 50,000. So the Mission is heavily gentrifying. It used to be a 90% Latino, now it's way less, but nonetheless, this is an area of the Mission, still about 60% Latino, still a fair number of quite poor people. And what they did is that they put up tents, 4 tents, and they did outreach to everyone in that census tract. And they tested about 3,000 people who either worked or lived in that census tract. And while they didn't get this almost 60% Latinos, they did get a nice mixture of folks in that community. And they reached 55% of the people in the census tract and about 57% of the households. So this is really pretty good, adequate representation. And what they found was that among people tested, about 2% had PCR positive for COVID. And that was about 1.4% of people who lived there and about 6% of people who came in to work. And when they looked at who tested positive, what they found is that among those who said that they can work from home, among those who tested positive, only 10% were able to work from home, whereas 90% were not. And that is very different from the overall population there, where 43% announced that they could work from home. In other words, it was hugely disproportionately, the people who tested positive were people who were unable to work from home. And then among the people who tested positive, more were men, 75% were men, as opposed to 54% in the entire tested group. And then while the tested group had lots of people of different ethnicities, of the positive tests, all except one were in Latinos, and the other one was in a Filipino. So really very, very different. No white people tested positive, and in this survey, in this instance, no other people tested positive. I was part of a testing group that did something similar in the Fruitville community, which is the historically Latino community in Oakland. And we tested people in September. And what we found is that of the people who live in that community, only 0.3% of those who were non-Latinos were positive. 5% of Latinos were positive. And then people who self-identified as Mayans, 8% were positive. And that same thing was true when we looked at antibodies. Almost a third of the self-identified Mayans tested positive for having been exposed to COVID in the past. Similarly, people who had a larger household size were more, as we go up here, were more likely to test positive here in the blue. So household size correlated with testing positive. And from these two studies, you can see how clearly the drivers of COVID excess risk among Latinos, working outside the home, coming home, and spreading the illness, unfortunately, spreading the virus, unfortunately, to other members of the household. And then in addition to that, what's driving death rates is comorbid conditions, particularly obesity, diabetes, and hypertension, and access to care. So when I start thinking about COVID and healthcare disparities, I tend to think of it like this. I see, where's my cursor? I see this first wave here in the purple, which is the wave, these phases of immediate mortality and morbidity from COVID. Then I see the second wave, all the people who now have who now living are COVID long haulers, dealing with those problems. We also see the impact of closing the hospitals on other illnesses like MIs and strokes. And then over time, we're seeing now the impact of interrupted care on chronic condition. People whose diabetes was well controlled and now it is not. People whose hypertension was well controlled and now it is not. And then finally, we have a wave of psychic trauma. And that one has affected, as you know, healthcare workers in addition to patients. And then for our communities, we particularly have economic injury. People in the Fruitvale study, we were amazed, but 60% of people in the Fruitvale are screened positive for food insecurity. This is an enormous number. And I think many of you, depending on where you are in the state, have seen big food lines like we've seen here in our Mission neighborhood. Why is that? I think you know that Latinos and Blacks are much more likely to say they do not have rainy day funds. They don't have reserves to be able to handle unemployment. I wanted to point out a few immigrant Latino specific issues. One of them is that we did a qualitative study with 30 patients in San Francisco and 30 patients in Denver, Colorado, people who had been hospitalized for COVID and discharged alive. What we found, and what many other people have found, is that people are delaying testing and then delaying coming in when sick because they're very afraid of two things: immigration, even though both are sanctuary cities in sanctuary states, and then a public charge. What is public charge? It is when permanent residents use services that have now been designated as public charge services, like Medicaid, where if a permanent resident uses Medicaid, they can become ineligible for conversion to citizenship. So we have seen lots and lots of people scared about this in a way that really surprised me. I think you all know that well, maybe not, that the taxpayer relief that was offered really excluded anyone who used a tax identification number to file their taxes. And many of those are undocumented people who are filing taxes. And in this way, it excluded many, many households where one person is undocumented, the other person is a US citizen. And the estimate is that this impacted 8 million US citizens, almost all of them children. So let's talk about policy issues. Some of the ones that I've been trying to address is the failure of OSHA, and until recently, the failure of California OSHA. Because making work safer has been such a high priority, the mechanism of doing that really is reports to OSHA. And the federal OSHA got so, under the Trump administration, I think did not come in and make any binding recommendations anywhere. And this explains that once we had meat packers in one state, we could get meat packers in another state with COVID outbreaks. Chicken farm or chicken poultry All of these things we're seeing again and again from factory to factory, repeated because of a failure of OSHA to act. The California OSHA came out with recommendations for COVID now in January 2021. That was a long time ago. There's an interesting study, and I have the reference here from Health Affairs, that where they looked at nursing homes, and they wanted to see, and they got the death data from different nursing homes, and then they looked to see whether or not that nursing home, whether the workers there were represented. And what they found is that people who had nursing homes where the workers were unionized were reporting fewer percentage deaths than nursing homes where the workers were not unionized. And it turns out that the union representation was associated with more protective equipment access for the workers, and consequently for fewer deaths for the people who live there. Another thing that's important to share is what did happen in San Francisco, partly as a result of that mission study that I mentioned earlier. Both San Francisco and Oakland passed right to recovery funds using philanthropic monies. They were able to substitute for some people the equivalent of minimum wage, so that people who tested positive would be able to isolate at home. This was unfortunately not available for people who needed to quarantine because they had been exposed, but at least it was available for people who needed to isolate themselves. And the other thing that's unfortunate is that because these are philanthropic funds, they run out all the time. So some weeks people are able to get these funds, and other weeks they are not. Another policy issue that we've been involved with, and where is trying to create, is to change the workforce. In San Francisco, over 70% of contact tracing that is being done among monolingual Spanish speakers. And yet our case investigators, most of them are not Spanish speakers. So here we have been using data to explain to the San Francisco Department of Public Health why language concordance is better than working through an interpreter for contact tracing and case investigation. And I was also fortunate, happy to talk about that, to secure some philanthropic funding to create a new contact tracing model by which we are able to do what we call enhanced contact tracing, where the person not only calls you up and says, okay, now you have to stay home now because you're positive, but also says, what do you need? Do you need food? Do you need isolation rooms? Do you need to be connected to lawyers? Do you need mental health access, and so on? So by connecting people with community resources. So I'm not going to go into this. Let's just pivot to vaccination. Obviously, the current frontier in our COVID work. First of all, I want everyone to be clear that while vaccine hesitancy is absolutely real, more real and much larger and more common among the African-American community than among the Latinx community, it is nonetheless real in all communities. However, it is interesting to me how much the mainstream media loves the narrative around vaccine hesitancy and has been slow to look at the narrative around vaccine access. So many of the ways in which we have been outreaching to people has been absurd. So reaching out to people over 65 on emails, reaching out to healthcare workers, low-income healthcare workers, again, only by emails or by MyChart portals where we know that people are differentially enrolled. I also want to talk about something that for me has been very important, which has been what I call a false tension, and that is efficiency versus equity. Because many people are saying, let's just do this by age, first 65, then 55, then 45, and so on. And part of the problem for that is that among Latinos and African Americans in California, if you look at people only 65 and older, that it does a really good job. It prevents 80% of the deaths among whites and Asians, vaccinating those folks. But among Latinos and African Americans, many of the people who die are younger than 65 and need to be vaccinated earlier because they are more at risk. So that is, and it's important to vaccinate earlier because if you vaccinate communities at risk earlier, leaving aside the fact that you'll have a bigger impact on mortality, you will also have an impact on transmission. And stopping transmission is our main goal now, particularly with the new variants, because we need to stop the virus from circulating and mutating. We can talk about how bad the outreach has been. So what are we promulgating instead? We're promulgating the need for community health workers, a sort of promotora type model. And we have a proposal in place now. We're going to see, it looks like it's going to be funded philanthropically to create sort of a community ambassador program to do vaccine education, go door to door and sign people up for appointments, et cetera, using youth from the state college, the San Francisco, the state system and city college system, as these are first generation youth who are bilingual, and often very culturally competent in terms of being in tune with what people are worried about. We're also really promoting partnerships with community-based organizations and with unions. We've created a speakers bureau. Wagata Samir is part of it. We have 60 physicians who are partnering with different community-based organizations and unions to give talks and answer questions about the vaccine. We have 84 engagements already scheduled. We've reached thousands of people already, and that has been a very rewarding thing to do, to be able to go online and answer people's questions through webinars and town halls. And then finally, there's clearly a need for a Spanish language social media campaign, as among the Latinos who died, 70% were immigrants, 70% were immigrants, and 70-ish, 75% or so had less than a high school education. So we really need to be able to reach our communities to let people know that the vaccine will be available and that it's free and it's not subject to public charge, but most importantly, that it is safe and not to pay attention to the misinformation that is circulating. So with that, I can tell you, as you already know, that COVID-19 has been a great revealer of disparities, but it's also been a great enforcer in that it's made poor communities poorer and hit sick people more. At the same time, I do think it has been an opportunity for us as health professionals to really do policy work and really partner with the public health system, to partner with social policies like the right to recovery funds that we got in Oakland and in San Francisco, and to help us redefine, in the same way that this program does, help us redefine what does it mean to be a physician or a dentist? What does it mean to be a champion? How can we get out there and do the work? So with that, I am going to stop, and I met my goal of being able to save lots of time for questions. I hope I didn't rush through too fast.
No, that was great, Alicia. Thank you so much. At this time, we'll go ahead and open up to questions. If you have a question, feel free to enter it in the chat box. Obviously, we have questions from Marie Buell. Marie, if you want to unmute yourself, but I know your question is about, we have many patients that are in the practice have been afraid to utilize Medi-Cal system because of the public charge rule, and just wanting to get a better sense of how to partner with you. Marie, if you want to speak directly to Alicia, go ahead.
Hi, Alicia.
Hi, Marie.
I'm in the office right now, so I'm on full PPE. Yeah.
Okay. Thank you for joining us.
Right.
I love your question.
Right. It's we're kind of in a conundrum right now because I've been working closely with MyCop to see what we can do, and the health equity issue is really a big issue in our farming community here. Yep. And I don't know what we can do to advocate more for them, because I just feel, and this is my personal feeling, I just feel that it is so unjust that we're recruiting these workers to come in from Mexico and other South American countries. but leaving them in the flapping in the wind, especially in this time of COVID. We've partnered with Friends of Field Workers so that we can help them providing food, providing clothing, providing dental kits and stuff like that. But because they are unable to access the healthcare system, they're basically waiting until it's an emergency to come see us, and only as a function of their parents of the kids that we see.
Yep.
So I really don't know. I wish there was something else that we can do.
I agree. And I think it's gonna, a lot of people, 20% of Latinos are outside the healthcare system, completely uninsured, and they rely on this mixture of charity cases and so on, which of course lends itself to exactly the problem you're pointing out. And I think that there's two things to do. One is to make sure that people who do have Medi-Cal are not afraid to come in. And that there, I think you could partner with the American Dental Association. I wonder if you could. I know that they have some progress.
Right. So I have been working with the ADA, actually with the CDA, so the California.
CDA, that's right. Yeah.
So I've been working with them, and we've been doing like more active recruiting of dentists. However, you can't blame the dentists, and
right.
because they, fool me once, fool me, that whole thing, right? Because back in 2008, when they reduced all the reimbursements down to 10% of what it is currently today, a lot of people got burned. And so there's a lot of people who won't even want to look at what it is that's available right now. Now, unfortunately, I work in a population where I think about 85 to 95% is agricultural workers.
Yeah.
So we have no choice here, right?
No, I agree.
And then you have a whole population of dentists in this area that's just competing for the business of the 15%.
Yep.
Right. And so you have all these offices here that are not serving the people that actually live and work in this area. It's insane. It's a shame.
It is a shame. And so thank you for the work that you're doing, and continue to advocate. I'm hopeful that over time this will get better because of advocacy.
Right. And we don't even know who we can, how far up the chain we can push. I don't know.
Yep.
Thanks, Marie. Let's see. I had a quick question for you, Alicia. You've had the opportunity one of the things that we try to do with this fellowship program, obviously, is we work on messaging and how to message to whether it's elected officials, to media, et cetera. So I was wondering if you could kind of talk to us a little bit about how you've been able to message to key officials, and how you've been able to integrate the message of equity so that is the consideration during policy discussions.
Yes, thank you. I think one thing that I have found interesting is how much data speaks. So both the mission study and then our own work in Fruitville has been really helpful in getting out specific messages around who's getting infected and some of their economic situations and the need for economic relief. In terms of messaging to the larger population, which is what we're doing now with vaccines, we decided that rather than adopt a more static messaging approach like billboards or things like that, that we would offer to give very short presentations, 8 minutes, 12 minutes maximum, and then spend the rest of the time answering people's questions. Because people want to get their own questions answered. They want to be able to say, well, if I have diabetes, can I still get the COVID vaccine? And they want to be able to listen to a doctor say, yes, you can and should get the COVID vaccine. Those sorts of questions, and really meeting people where they're at in terms of their fears of, was a vaccine rushed, or fears of abuse, and so on and so forth. So I think that we're very interested in dialoguing. And before, we were thinking more about how to craft the right message. And I still think that's really important. but now we've come to rely more on that it's also the dialogue. It's giving people the opportunity to ask their own questions, which is very labor intensive, but we can do it. I see that there's some hands up.
Yeah, Shakalpi Pendekar, Dr. Pendekar, do you want to unmute yourself? There you go.
Hi, Alicia. It's so great to see you, and thank you for the wonderful presentation. And to your point, yes, data is very important, and that I think is what's lacking to a certain extent at the state level, right? I mean, you've done these studies, and you are able to share your data, but I don't know if that's the case in all the counties across the board.
Right.
So that's one thing. But the other thing I wanted to ask you was, in terms of public health departments, right? So what more can public health departments do to get the information out? Because you brought excellent points, which is where I've been scratching my brains too, in terms of, okay, make appointments for vaccines, you're 65 and over, but I don't have a phone, or I don't have access to that. So, so even if a public health department decides to put COVID information, resources, vaccine information on their website, you're still missing on all those folks who don't necessarily have that access. So how can that be addressed? And I in your presentation, you mentioned outreach workers, but that would again mean, either pulling from other programs within public health, or having the funds, which most public health departments are going to tell you they don't have the funds to hire new people. So how do you see that being addressed?
I think that the federal government is in the new COVID relief bill that the federal government is trying to pass. There are billions of dollars that of which millions are for vaccine outreach. And what I would do is partner right away with your local health department to get those monies. And then I would use them to hire people from the community. Either in our case, we're partnering with San Francisco State students and City College students, but I would use them to hire young people or just other people from the community under this sort of caseworker promotora model, where they're paid by the hour, and they go out and you train them to answer questions, and you train them to help people sign up for the appointments and talk about the logistics. So we are instituting a training, and maybe what we can even do, you're giving me the idea, is to go statewide with the training, and people can come and be trained online by us about the vaccine, and then be trained by the local health department on the logistics of whatever needs, or the local health system on how to do that. But we cannot solve this problem with the health workforce we have, or with the resources we have, because our workforce doesn't have the linguistic and cultural competency, nor is it set up to do the sort of outreach programs that are necessary.
I think sharing statewide would be an excellent way to go, Alicia, but also maybe partnering with some of the local channels too, right? Every pretty much county has a local TV channel or radio channel that might be, sort of in the public space, and
yes,
is Spanish, catered towards the Spanish community. So maybe that's another way to go. Okay, thank you.
Thank you.
Alicia, I wanted to, we have another person with a raised hand, Kristen Hughes, a new fellow to the program. Kristen, do you want to go ahead and unmute yourself? Okay, great, go ahead.
Yes, hi, thank you very much for this information. I'm a pediatrician with the county, Santa Barbara County, and in our county clinics, we are seeing just anecdotally what seems like a great disproportionate number of cases of children with worsening acute on chronic obesity. And it seems like there are many factors, unfortunately, working against them. They're spending, seems like a disproportionate number of hours on the screen for school, and many other factors. However, like you said, data is important, and I have tried to reach out to our county to get data, and there seems to be some difficulty getting this. They're even saying I might have to pursue an IRB. So I am not able to get the data, to get the information out there to the schools and the community. So I've decided to try and access the data through SenCal, since most of our patients are insured by SenCal. And it seems like they are willing to potentially work with me to get me the information. But any other suggestions on how? I gave them a list, I think, of about 12 diagnosis codes, obesity, broken down by the various BMIs, but also pre-diabetes, non-alcoholic fatty liver, dyslipidemias.
Okay, great.
So, but any other advice on how to try and get this type of data so we can get this information out to people?
I use a lot of data from CHIS, which you can get, the California Health Interview Survey. And if you go to that website and go to the box that says Ask CHIS, you can get county level data on a lot of variables. So see if that helps you.
Thank you.
Yeah. I know is it Muriel?
Muriel, if you want to ask a question, go ahead and unmute yourself.
Yes. Hi, very nice to meet you, and happy. I'm so encouraged by hearing all of this. I think that there was a lot of compelling information and data that was presented, and I highly encourage everyone, because we have this persuasive narrative series that was meant exactly for this purpose.
Yes.
And it is all about taking heavy data, but putting a human spin in terms of storytelling, so that you can create more of a balance in the media space of what type of stories are being told. I do understand that there's such an off balance, but these types of stories that you are anticipating in your different areas of expertise, in your different areas of the interaction that you have with the patients or with the community, is exactly the type of storytelling that we're wanting to do with in Champion Providers.
Well, thank you for saying that. I was thinking that what Marie talked about people waiting till they have a mouthful of pus to come in, that would make for a very compelling story. So I think it's a wonderful part of this program, and thank you for reinforcing that. Pedro, do you have a hand up?
Yeah, Alicia, can you hear me?
Yes.
Yeah, I agree with all my colleagues. I think we are very thankful for you, Alicia, for putting in perspective what we all clinicians have seen all throughout the pandemic. And I think hopefully your study will help change policy. And
I hope so.
One of the things that I have experienced during this pandemic is the realization that we physicians have had opportunities in this pandemic to reach out our community partners and start and develop partnerships and coalitions that have the potential to help right now our farm workers. And I just want to share just briefly some of the partnerships that we have had in case any of the fellows can replicate that in their counties. Here in the Salinas Valley, from the beginning of the pandemic, we had a coalition that with the farmers who were eager to learn from us, from the physicians, about how to contain the virus, because it was going to affect their bottom line. And we also had our medical legal partnership, who was able to find income replacement for our farm workers, and encourage all of us to start using the state disability program to provide some income replacement to our patients. And we also partnered with UC Berkeley and with the researchers from the Chamacos study, who were able also to I think do one of the first studies also nationwide about COVID in the farm workers in communities. And religious organizations also came on board, and we were able to push the health department to develop community health workers that were bilingual, like you did. And finally, we also even had the fortune to get PBS engaged, and they did a national documentary about the plight of farm workers during the pandemic. And so I think that some of the skills that we are getting in the fellowship, I think they are very important because they're helping us to really, again, hold hands with all those partners who are even, I think, more important than physicians to take care of this pandemic. So I want to thank everyone in the fellowship for giving us those skills, and also for the other fellows who have inspired me also to continue doing this work.
Thank you, Pedro. That's very inspiring to me.
Alicia, I wanted to do a quick time check because I know that you.
Oh, yes.
Well, we will have to cut a little bit early, but yeah, so I just want to see where you're at with time, and if you need to hop off, I want to provide you an opportunity to say a few final words.
Thank you very much. I do need to hop off, but I hope that the rest of you continue to talk with Alana and bring out some of the policy, some of the ways in which we can partner with community-based organizations, with unions, with local health departments to do the work that we all want to do. And I'm sorry that I need to go. I wouldn't do it except that I'm giving a vaccine talk now to community-based organizations, and I didn't realize that we weren't finished until 1:15. Thank you very much for the opportunity to talk with you. I feel wonderful to be a little part of this program that connects me to such wonderful physicians and dentists throughout the state. So good luck to all of you, and thank you, Alana, and thank you, Agata.
Great.
Bye-bye.
Thank you so much, Alicia, for your presentation. I think Wagata is still muted, but just wanted to thank you all for your participation today. And we will have a recording of the presentation posted online by next week. And just wanted to highlight some of the, I think we are hoping to have this discussion because I think with the COVID pandemic, as Alicia discussed, it really has uplifted a lot of the disparities that were always there, but really kind of brought them even more so to the forefront, which is the acuity of the pandemic. So we'll continue to have this conversation, and integrate issues of equity into all of our discussions, and really encourage everybody to really focus on when they're speaking with, partners, when they're speaking with local health departments, whoever it may be, to really uplift issues of equity as we move forward into this important work. So now no communities get left out. So with that, I think I will close out today's discussion. Wanted also to give that final plug, as Muriel had mentioned, for our persuasive narrative series that will be coming up at the end of the month. So with that, we'll go ahead and close out today's presentation. Thank you all once again for all the work that you do, and we look forward to moving forward. Take care.